Okay, our next case will be presented by, I'm going to probably mess this up, Cherie Fathi, excuse me, from the Wills Eye Hospital. The title of her presentation is Infected.
Thank you all so much for having me. My name is Cherie Fathi. I am a second-year resident at the Wills Eye Hospital, and I'll be presenting a case aptly called Infected. Our patient is a 64-year-old female with a history of diabetes who presents with pain and decreased vision in the left eye. She's had a corneal ulcer for the last 4 weeks that is culture positive for Pseudomonas. She was appropriately started on topical fortifieds and was actually status post a tap and inject 2 weeks prior to presentation to our ER for suspected endophthalmitis. She was admitted to an outside hospital for IV antibiotics and was not getting better, so she was discharged and sent to the Wills ER. On initial examination, she has light perception in the left eye. There's no view to the pupil. She's soft by applanation, and she's unable to do visual fields, as might be expected. Her past ocular history is significant for denying a history of contact lens wear. She denies a history of trauma, denies a history of herpetic or autoimmune disease. She does have a past medical history of diabetes and hypertension, no past surgeries. She's on the kitchen sink of medications, including antifungals, antibiotics, anticoagulants. Her social family history and allergies are non-contributory. Here she is on presentation to the Wills ER. You can see that her conjunctiva is pretty boggy, ecchymotic, and injected. Her cornea has diffuse stromal edema with 40 to 50% tissue loss in most areas, 80% loss in the nasal area, and she has a large 9 by 10 millimeter epithelial defect, as well as a 3.5 millimeter hypopyon in the AC. And then when you pull down her lower lid, we see this large infratemporal scleral abscess measuring 4 by 6.5 millimeters. This is suspicious for infectious scleritis, but interestingly, the spot is not contiguous with the corneal infiltrate. This is her examination in summary. We also performed a B scan in the Wills ER that was suspicious for vitritis. In the ER, from the ER, she's admitted for IV antibiotics and a corneal biopsy. Her current medications, we whittled it down to just the fortified tobramycin and moxifloxacin every hour around the clock, and we kept her on her anticoagulants and added atropine. We also recommended a retina evaluation. When retina saw her, they said the B scan was flat without vitritis, no choroidal effusions or masses. They recommended subconjunctival antibiotics at the time of corneal biopsy and also recommended a workup for inflammatory scleritis, which all returned back negative. She was taken to the OR where she had a corneal biopsy scraping and a scleral AMT patch graft placed. She was injected with subconjunctival cefazolin and gentamicin, and postoperatively she was kept on IV antibiotics for 2 days before being transitioned to oral moxifloxacin. Corneal biopsy returned nonspecific with no organisms, and unsurprisingly the cultures came back negative. She had been on antibiotics for about 4 to 6 weeks by this time point. Here she is at postoperative week 1. The corneal infiltrate is improving, and the scleral infiltrate is also improving slightly, but there's this large area of scleral melt. And as my mentor, Dr. Rapuano, who's a cornea specialist, said, it's never exciting for an anterior segment specialist to be seeing uvea at postoperative week 1. So we're a little bit nervous at this point. Here it is up close with the scleral AMT patch graft. It's still about 8 by 6.6 millimeters, epithelial defect with around 50% thinning centrally. Her visual acuity is LP, her pressure is 4. She's brought back to the OR 6 days after admission for a corneal double layer AMT and partial thickness scleral patch graft. And she's continued on her fortifieds, her atropine, and PO antibiotics, as well as her anticoagulants. Here she is at postoperative day 1. You can see on the cornea there's a double layer AMT with 1 layer sutured, 1 layer glued. And infratemporally there's an amnioguard. And as a review for the residents, there's an amnioguard and an amniotic transplant placed over it. The amniotic transplant provides anti-inflammatory properties which assist with scleral wound healing. And the amnioguard is actually a thicker cryopreserved amniotic membrane that provides durable tensile strength to the globe. Visual acuity is still LP, pressure is 4. And she started at prednisolone twice a day. Here she is at postoperative week 1. She's feeling much more comfortable now. There's still a pretty sizable epi defect, 3 by 2 millimeters. She's still about 50% thin centrally, but she's feeling much more comfortable. Infratemporally, we see that the amniogard has vascularized. There's still this area of scleral melt. And at this point, when we're seeing her postoperative week 1, we're just hoping for this infectious area to clear and to epithelialize before, for us to think that we may have a chance to salvage her globe. Visual acuity LP, pressure of 2. Postoperative week 8, she's feeling much better. There's no active infection at this point. The hypopyon is gone. She's still pretty shallow. There's a pretty diffusely edematous cornea, but there's no epidefect. There's only pooling at this point. And she's shallow peripherally, again, no hypopyon up close. Infratemporally, the amniogard has vascularized. The area has completely epithelialized, and there's no active infection. Here it is up close. Visual acuity is light perception, and the pressure is 2. At this point, the patient has a pretty impressive, her vision has been LP the entire course. Her pressure has been persistently low. She has significant corneoscleral damage. And the thought is, what would be the next steps for this patient, which I posed to this panel, and also, what do you think caused this patient's infectious scleritis, especially given that she has no history of contact lens wear, no history of trauma, to think of the common causes.
May I ask a question? You mentioned the history before presentation with tap and inject. Mm-hmm. Do we know anything more about that? What led to that diagnosis, presumed endogenous endophthalmitis?
So I think they thought it was still, so she tested culture positive for Pseudomonas. So the thought that there was Pseudomonas on her flora on the cornea, but there was no source for endogenous endophthalmitis, and she was injected infratemporally.
And the tap, there was no results from that?
No results, no growth.
And the scleritis area, infectious scleritis area, was the area where they tapped and injected?
Yes.
Okay. And there was no hardware in the eyes, no scleral buckle?
Nothing, yeah.
And was there a reason why they or you guys did not do PCR from the samples rather than solely relying on cultures and staining?
That's a good question. You know, we don't commonly do PCRs at Wills. It's not something that we do routinely with our AC cultures either. So I don't know that I have a great answer for you, and the outside hospital didn't pursue one either.
And so you guys, I mean, she healed nicely, fortunately, but you have not been able to identify the organism.
It's Pseudomonas.
Oh, it's Pseudomonas. It's confirmed. Okay.
Correct.
Okay.
But we don't know why she got it.
Okay. And from your cultures or stainings, that was confirmed as well at Wills?
By the time we repeated the culture, she had been on antibiotics for about 4 to 6 weeks, and so our cultures came back negative.
Okay. Okay.
So do you think the scleritis and the corneal infection are the same thing, or did these, what's
You know, I am not sure. So typically, infectious scleritis or inflammatory scleritis does not cause hypopyon like that. The only thing that would cause that bad of a scleritis, if it was inflammatory, would be an ANCA-associated vasculitis, previously known as Wegener's, but that does not cause hypopyon like that, right? So as soon as you showed it, I did not think it was inflammatory. That's what I do. And infectious was the right way to go, obviously. The site of the injection and tap being the same as the site of the infectious scleritis made me think there is a chance that these two sites were infected by the same microorganism. And it did respond to the same therapy, right?
Yes.
I was worried about fungal infection because the scleral wall infection that bad can be fungal, but then most fungi that affect the sclera that badly will create vitritis as well. So aspergillus was one of the ones, and it will progress to a panophthalmitis very quickly, and it didn't happen in this case. So that put it lower on the differential.
Right.
All right, before she finishes up, Sandy, Basil, do you want to fix this lady up or clean her out? Or
Not now.
Not now? Not ever?
Now, well,
Here's my-
she's got hypotony. Her ciliary body probably isn't pumping very well. I think the objective is to let her stabilize completely. It may be 3 months, 6 months, and then decide what to do with the anterior segment. See if the retina is still flat. Try to figure out where to go. If her retina is necrotic, there's no point in doing surgery.
Right. So one of the thoughts from Dr. Raber, who's a cornea specialist at Wills, was that you could try a PK, a therapeutic PK, knowing that it would fail, but you would see if there's any visual potential. So at least you'd kind of buy seeing if there's any, utility in doing anything further. And then given the hypotony, you would do a K-Pro. She wasn't very excited to do any further surgical procedures, and I totally understand. So we'll keep watching.
Sometimes saving a globe is enough in a situation like this. You don't have to be heroic and wind up with a glass eye.
Correct. Sure. If we could go back to the slides. So we agreed. It looked like in this case it was an infectious scleritis. Interestingly, this patient did not have the common risk factors, which are usually trauma or even a remote history of pterygium surgery. There are cases of infectious scleritis happening up to 20 years after a pterygia surgery, but she had none of those risk factors. Is not a contact lens where the most common agents are Pseudomonas, strep, and staph, though atypical bacteria and fungi have been implicated as well. In this case, the average time on topical antibiotics usually is 96 days in patients with infectious Pseudomonas scleritis. It takes about 63 days for these patients to clinically resolve. And similar to the SCUT trial, there was no adverse effect for starting PO steroids after 48 hours of antibiotics. In terms of the tap and inject, there have been other study case reports that have reported necrotizing scleritis after being injected here with intravitreal ranibizumab both with intravitreal injections after a retina procedure. So in summary, we have a case of a Pseudomonas keratitis scleritis complicated by an intravitreal injection. The infectious scleritis may masquerade as a necrotizing inflammatory scleritis, so it's very important to have a high level of suspicion for an inflammatory cause, especially ANCA-related. Pseudomonas scleritis is severe and globe-threatening condition, and we show that it requires extensive treatment and monitoring, and you can successfully stabilize and salvage the globe with an amnioguard patch graft. Thank you all very much.
Wonderful. Does this all come, for the guy who doesn't do this for a living, does this all come together as just a bad corneal ulcer, maybe endophthalmitis, intravitreal injection complicated by scleritis? Is that the sequence of events, or were they just two separate loci of infections that happened to be where you got the injection?
Our suspicion is that it's from the intravitreal injection having there was seeding from the corneal ulcer.
And no depot steroids were given during that tap and inject, right?
None.
Because I've had cases like that too, that would just set the stage up for a really bad infection.
Right. Thank you.
Final comments, panel? Okay, thank you very much.
I do have another comment. Of course, any procedure we do is fraught with possible danger and risk. And I don't think anybody should ever be so gallant as to think, oh, I can do a procedure and I have no risk. I see it every day in my practice, and it's heartbreaking. He didn't tell me, she didn't tell me, I didn't know I was going to have a complication. Anything we do as doctors has a risk, whether it be an intravitreal injection or anything has a risk. And I think we all need to keep that in mind.
Are there thoughts that it's controversial about which type of the way you prepare your injection site, whether there's more risk of this compared to other ways, what you do with the conj, how you use antibiotics, or would you have done something special if it was a corneal ulcer patient versus the myriad injections you must do every day and not?
No, I just think that the attitude that's being taken about antibiotics is not appropriate, and the literature needs to be read that the use of post-injection antibiotics is not correct. Pre-injection antibiotics is not correct. And again, it doesn't matter if we're doing a simple anterior chamber paracentesis for whatever reason, or doing a glaucoma procedure, while glaucoma people are tapping anterior chambers all the time. Every single time you stick a needle into anything, the patient is at risk. Betadine, betadine, betadine. And by the way, if they're allergic to betadine, what do you use? Betadine.